much. So thank you so much for having me here today. I'm so happy to be here at this meeting. I was really happy to be joining the CTN this year as an investigator, and as a team, we were really thrilled to be joining the CTN as the SHAWNA Project, CTN 333. So I will take you through this project. So I first want to give a land acknowledgement as well, and acknowledge that the land that we do our research on and our work on is largely the unceded and traditional stolen territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And on the right, you can see a picture of our elder blessing and opening of a mural in our Hornby offices by Elder Roberta Price and Gleda Morgan. And we have another mural at our other space on Hastings as well. So SHAWNA is a community-based study. It's longitudinal, and it was initiated in 2014-2015 as part following 6 months of extensive community consultation with clinical and community partners. We have an amazing qualitative and arts-based piece since 2014 as well, led by Dr. Andrea Cruci, which includes a really fantastic photo voice piece. As part of the quantitative cohort, we have a clinical piece whereby we offer sexually transmitted infections testing for participants. And we also collect viral load and CD4. We work closely with our study physician and the site PI at Oak Tree Clinic, Dr. Mary Kessler, and do a lot of our recruitment at Oak Tree as well. And just thank you so much to Oak Tree for being really welcoming to us, including Dr. Gina's Ogilvy and Europic, who really facilitate a lot of our recruitment. Our quantitative cohort includes a baseline survey and then follow-up surveys every 6 months, which are administered by trained, experienced interviewers. Our inclusion criteria includes cis or trans self-identified women who live in or access care in Metro Vancouver and who are 14 years of age or older. We were successful in funding from the US National Institute of Mental Health and CIHR, as well as CTN. And we are funded through to the end of 2025, beginning of 2026. So trying to combine some of these funded objectives together, I've listed our 3 main objectives here. So the first one is to understand through what mechanisms do interpersonal violence and stigma affect health services access among women living with HIV. And we look at a variety of outcomes, including HIV treatment and care, as well as primary care, mental health care, and dental care. We are also looking to understand what the components of trauma-informed HIV care and practice are with women living with HIV, and how do these individual or combined components support improved access along the HIV care continuum. We're also really interested in understanding how we can ethically and meaningfully build a platform for doing trauma-informed care research with women living with HIV, and also trying to understand how this research can be really useful, including potentially to inform the development of trauma-informed HIV care and practice intervention. SHAWNA follows an extensive community guidance strategy. We have a positive women's advisory board made up of 12 to 15 women living with HIV, some of whom have been on this board since 2014, 2015, so quite a long time. And this board meets every 2 to 3 months. We met a bit more frequently in COVID, but it was remote. And we share research findings of the study, we seek input, they provide guidance, and then they provide a lot of support as well to each other. We have a community engagement associate team who lead and facilitate the Positive Women's Advisory Board, and who are also members of our community advisory board of about 10 organizations. And with these groups, we meet annually, but with some partners, we meet quite a lot more frequently. So SHAWNA is a longitudinal study, and so we know a lot of our participants for years. We place a lot of emphasis on not just doing extractive research, but also giving back to participants. And so we have an extensive clinical and community referral and outreach program. We have events, we can do outreach, we meet participants where they're at. Our interviewers and outreach workers are highly trained and come from a lot of different backgrounds, including housing, food, mental health, counseling, and are really experts at connecting participants or reconnecting them to services that they might need, things that come up in the interviews, and making sure that they have everything they need. So COVID has had an impact on that outreach, certainly, and on connecting with participants. We've done a bit of analysis on this, and we can say that on average, over COVID, we saw 25% fewer participants than we did in the time periods before that. We found that we are less likely to see participants who at their most recent COVID interview were Indigenous and or otherwise racialized versus white, sexual minority versus straight, gender minority versus cis. And we are also less likely to see participants who in the last 6 months had lived in the downtown east side, used non-injection and or injection drugs, and experienced violence, and who are not on art. So this really paints a picture of what we would expect. We're missing the most marginalized people who don't have access to technology or phones as easily as others, and who are living in precarious housing situations. We also know that the drug poisoning epidemic in Vancouver and BC has had a huge negative impact on our participants as well. We try to make our results vibrant and colorful and easy to read. And so this infographic just shows a summary of some of the characteristics of SHAWNA participants in collaboration with our community engagement associate team. I won't go through all of them, but you can see that the median age at baseline of participants is 43 years. About a third are sexual minority, 10% are gender minority, over half are Indigenous, and about a third white, 5% Black, and 4% other racialized participants. In addition to the objectives that I showed you, we do a lot of research on a number of other themes. We have a really large, long questionnaire, and so it has a number of different topics. We've had a big focus on incarceration in the last 5 years, as well as the criminalization of HIV non-disclosure, led by Dr. Chrissy. We continue to see that HIV stigma and discrimination is a huge barrier to health services access for our participants. We do a lot of research there, and also on gender-based and interpersonal violence. We've done a few fantastic studies on access to cultural safety, and we're continuing to grow this research with Indigenous women living with HIV. We really view building Indigenous cultural safety and decolonizing research and practice as a journey and a process, and not something that we have arrived at yet. And we engage with our Director of Indigenous Research, Dr. Brittany Bingham, who's a co-investigator on these projects, and also leads a study funded through CIHR that looks at health access among Indigenous women and draws on SHAWNA data. We continue to work closely with our community partner, CAN, and really trying to understand how we can continue to engage the voices of Indigenous women living with HIV. And we will be presenting a workshop at Wise Practices in a month. So we're really looking forward to that. Our spaces, we strive for them to be culturally safe, but this is also an ongoing process. On a project level, we work with participants and work on sharing circles and engage Indigenous women as expert consultants. If you haven't had a chance to see our Sajishi Spotlight series, we do have a number of amazing talks on decolonizing research and practice there as well. So one of the benefits of having a longitudinal study is that we can look at changes over time. So I just want to highlight the study done by Carmen Logie, which will be presented at the AIDS conference. And it's just a flat line, which isn't, incredibly interesting at its start, but you can see that over these 5 years, the first 5 years of SHAWNA, HIV stigma as reported by participants has not changed, which we would have loved to see it decreasing. And the same is true for everyday discrimination on the right. We have a number of different ways that we're really hoping to engage with participants and the community and clinical collaborators, as well as policymakers. So we do create a newsletter that we present biannually. We're working on a visual and infographic-based report of research, which we hope can also be used as posters. We are excited that we're able to do more working groups, sharing circles, and participant-driven research forums as things open up a little bit, hopefully. We continue to do arts-based research and are working on a digital storytelling project as well. We hope to produce a toolkit on guidelines of trauma-informed practice with women living with HIV. And if it makes sense for community and in the context of the results of our studies, we would plan to work on a protocol for a trauma-informed intervention to meet the needs of some of the more marginalized participants in our study. Some of our research lends itself well to policy. And so we work to translate some of our research into more digestible policy briefs, which we can then disseminate to a larger audience. So I'll just give an example. This is our newsletter, which we put out biannually in the summer and winter. And here, this gives an example of a study on the left, which was then turned into a policy briefing note and disseminated to key stakeholders. This is the starting piece of our infographic visual report. On the right is an entire study broken down into smaller pieces, which I find very difficult, but our KTN comms team has been amazing in supporting this. So, and we've had some positive feedback on these pieces as well in their ability to engage participants, as well as be brief snapshots that can be used for further funding and support for others. So I'll just close by saying thank you so much to all of the participants and our SHAWNA team, as well as SHAWNA research and administrative support, and our community partners as well. Thanks again.